We go. Okay, thank you very much. Good afternoon. It is my pleasure to co-chair this section with Professor Thille, Professor, whatever. And the title this afternoon, I'm Marco Ranieri, by the way, from Italy, Endotracheal intubation, when and how. And I would start right away with Dr. Schenck from Cornell University. The podium is all yours.
Okay. Thank you very much. I'm honored to be part of this very physiologic-based study, and I hope to provide some evidence based on observational research and how we can think about this as we're generating evidence to perhaps inform how we think about trials in the future. So the title is a little bit controversial, I guess. The guidelines don't guide the optimal time to initiate mechanical ventilation. These are my disclosures, which are not relevant for this talk. But the first question I'll pose to the group, which is a little bit rhetorical, is, are there guidelines for the initiation of mechanical ventilation? And if you drill down to the meat of perhaps the British Thoracic Society for a failure of non-invasive ventilation published something in 2007. However, what they published, if you trace back the history of this, when non-invasive ventilation was first used in the setting of de novo hypoxemic respiratory failure or hypercarbic respiratory failure, there has been a chain of basically expert agreed upon clinical trial criteria, and the establishment of these criteria, usually some combination of peripheral oxygen saturation with some degree of supplemental oxygen or FiO2, some rate, some degree of tachypnea, whether it's 30 or 40, some visible sign of increased work of breathing, some change in their pH, some change in their neurologic score, and then some amount of hemodynamic instability, together with some inability to clear secretions or manage their airway. It was just decreed that these were the levels, and then they have stayed together for the outcome for clinical trials going forward in time. So if you look over the 20 years, without really prospectively evaluating if these levels could be any different. And then, aside from not having clear guidelines, we have these predictive scores, which may signal to clinicians taking care of patients that the patient is more or less likely to fail non-invasive respiratory support or high-flow nasal cannula in this instance. This is the ROX index, which is the ratio of the SpO2 to FiO2 over the respiratory rate, and a lower ratio is predictive of failure. So as your respiratory rate increases relative to your SpO2 to FiO2 ratio, and you result in a smaller score, you're more likely to be treated with mechanical ventilation. However, if you look at the derivation of this predictive score, they still actually maintain the same rules, or guidance was given to the hospitals that participated in the generation of this score, that the same rules were suggested as the indication to initiate mechanical ventilation. So there's other scores. This is a Chinese group that came together with a more complex score looking at failure of non-invasive ventilation as opposed to high-flow nasal cannula, combining things like heart rate, pH, GCS, PF ratio, and respiratory rate, with a higher score being more likely to be predictive of failure of non-invasive ventilation. However, if you look at the methods section for the development of this score, they also used the same expert-derived guidance on when to initiate mechanical ventilation. So what are we actually trying to accomplish with this decision for using non-invasive support versus mechanical ventilation? This is a survey of intensivists, specifically in septic shock, but when to initiate mechanical ventilation, the factors that they are considering. We are looking at the risks of initiating mechanical ventilation, including that everyone is well known of ventilator-induced lung injury, hemodynamic deterioration, ventilator-induced diaphragmatic dysfunction, et cetera. However, the benefits, including the decrease of your work of breathing, redistribution of cardiac output, and prevention of inflammation from your own diaphragmatic work. And then the results of the factors that these intensivists from the same study considered important is that the hemodynamic criteria was less likely to influence their decision to initiate mechanical ventilation when compared to respiratory criteria or neurologic criteria. But a lot of these terminologies are vague. Everyone said that it was very likely that hypoxemia is an issue, cyanosis, respiratory distress, but there's not an objective definition of what these would mean in any particular sense here. So what question are we really trying to answer? So I'm going to use the same setup that I want you to keep in your mind as we go throughout this portion of the talk. Is a patient, a 63-year-old man with diabetes, presents with a few days of fever, cough, and develops breathlessness. That circle on the left-hand side of the screen is when he enters the emergency room, and then time is following on with the arrow. He's anxious, he's tachypnic, he's hypoxic, and then he's treated with non-invasive ventilation. So non-invasive ventilation is initiated at some time. And what we are trying to really figure out is several questions. One is this idea of the counterfactual is, at that time of initiation of non-invasive ventilation, what if instead we initiated invasive ventilation? And then the question, the comparison or the counterfactual world that we would attempt to address is, do we do non-invasive or invasive as a primary therapy? But then there's a different question, and that's the one where I'm going to be addressing a somewhat more detail, is that what happens if non-invasive ventilation is started at time 0, or time 1, and then invasive ventilation is started at time 2, or if we stretch out that second time point and invasive ventilation is started later. And so that sets up a different counterfactual, which is the idea of early rescue with invasive ventilation versus later rescue with invasive ventilation. And let's look at some of, and so you could say what happens if someone fails non-invasive ventilation earlier compared to later. And there's actually a fairly robust observational literature on this topic. And the first sort of question is, when does this happen? If you look at different cohorts around the world, this has remained stable over time, is that usually the first 48 hours are when patients fail non-invasive ventilation. You can look at the proportion on the left-hand side of the screen of when patients are intubated, and on the right-hand side of the screen, this is the hazard of intubation by hour. And then if you stratify patients, this is a little bit of an older study, but if you stratify patients by whether they fail early within the first few hours or whether they fail late within the first, up to 48 hours, you generally get curves that look like this. And so this is Kaplan-Meier for total survival. The gray curve is the late failure, the black curve is the early failure. And the early failure takes a mortality hit at the beginning of the experiment due to a process known as immortal time. So immortal time is the fact that the patients in the gray curve had to live for 48 hours in order to be intubated. So all of the early deaths are not counted in this observational research because by definition, in order to be intubated at 48 hours, you had to live for 48 hours. However, repeatedly, if you look at the patients who are intubated later, and this is a more recent study looking at the days since arrival into the ICU. This is primarily patients with immunocompromised status who are treated with non-invasive ventilation. The day in which you fail, as you go forward in time, the risk if you fail and are intubated goes up. And so despite the fact that, even accounting for immortal time and all these other factors, when mechanical ventilation is initiated later, the patients in whom it is initiated on generally do worse. So as a halfway point summary, observational research in this space is challenging. Immortal time and potential biases related to the total population at risk makes this direct comparison difficult. Because what happens if we increase our threshold to intubate? So instead of the first counterfactual that I set up as if you fail early versus you fail late, there's a third option, which is you never fail. And so most studies looking at failure of non-invasive ventilation generally, or a lot of studies, and I won't say most studies, a lot of studies are looking at the difference between the first group and the second group and not accounting for the third group. So in one way, for accounting for the third group, we in the setting of the early COVID pandemic in New York, where we went from 0 patients to 500 patients in the span of 2 weeks at our hospital, and we had rapidly changing guidance in terms of what our intensivists were meant to do on the timing of initiating a mechanical ventilation. Very early in the pandemic, there was this on the face mask or non-rebreather, and if you were failing that, you were initiating mechanical ventilations, and so a proportion of the patients were treated with that strategy. And then there was an intermediate strategy where there was more practice variation using high flow nasal cannula, non-invasive ventilation. And then as the pandemic progressed, even within those first 4 weeks, we had what was called a prolonged observation strategy. And so the way we set up this analysis is we defined an at-risk cohorts, which means all patients were included in the cohort were treated with at least 6 liters of nasal cannula or high flow or non-invasive ventilation. So even if they never progressed to mechanical ventilation, they were still included in the cohort. We adjusted for the hospital strain, which is a function of the number of patients admitted because we were having ICU patients on the floors, et cetera, et cetera. And we corrected for CDC-based guidance for factors associated with outcome of mortality. We also adjusted for the SOFA score at the closest onset of 6 liters nasal cannula. And so some of the results is that, when you go from early to prolonged, at least in this cohort, on the early ventilation side, 80% are intubated at the time of hypoxemia. In the prolonged time, goes down to around 50%. The mean SF ratio at the time of intubation goes from 200 down to 155. And in terms of the early group, you get more AKI, you get more tracheostomies, you get longer length of stay if you intubate more people. However, the mortality across all of this, keep in mind adjusted for SOFA score, adjusted for hospital strain, was actually the same. There was an important interaction, though, with your SOFA at the time of eligibility or hypoxemic respiratory failure, meaning that if you're in the prolonged observation group and you had a very low SOFA score, not including the respiratory function, you were likely to do better with just observation, whereas if you had higher SOFA scores, you were likely to do worse. This is a graphical representation of this. On the left-hand side of the screen, you can see the hazard ratio for mortality in the low SOFA at the time of hypoxemia versus the hazard ratio at higher SOFA scores. And I will end with some really compelling work by investigators out of University of Toronto, where there's 2 studies tied together that were kind of a target trial emulation for looking at what happens within the MIMIC database and the Amsterdam ICU database if you hypothetically modify the timing of intubation at different SF ratio thresholds. So you take what the observed timing of intubation is. Maybe some patients get intubated at SF ratio of 90, some are higher. But what you do is you clone their data and change only the timing of intubation relative to their SF ratio. It's a little bit hard to wrap your mind around the steps to this, but the results are pretty interesting, meaning that, as you would expect, is when you intubate at a lower threshold, you intubate less people. And so that's all of these spaghetti plots leading to the proportion intubated with the SF ratio less than 110 versus less than 88, and this was seen across their 2 cohorts. However, there is very minimal change in mortality, at least in this kind of hypothetical target trial change, where there's a subtle increase in mortality when you intubate at a lower SF ratio in the MIMIC cohort, but that was not seen in Amsterdam. And the same group, using the same data sets, asked a different question, which I think will inform a little bit of this conversation, which is they took a look at many of the factors that are associated or recommended as the decisions to initiate mechanical ventilation, such as different SF ratios, versus the presence of vasopressors versus different ROC scores versus different HACOR scores. And this figure is a little bit complicated, but what it is when you meet each threshold, at least within these 2 databases, what the probability of you being intubated within different time frames. So the color in blue is 3-hour time frame, the color in red is 8 hours, the gray is 120 hours. And you can see that for when you meet most of these thresholds, less than 10% or 20% are intubated within 8 hours. And if you can carry forward less than 50%, even with the most restrictive PF ratio threshold, are intubated at 120 hours. And this, again, is seen in the other cohort, in the Amsterdam cohort. So with that, we'll conclude at saying randomized clinical trials of respiratory support generally include guidance that may not reflect secular clinical practice. Observational research exploring this question is extremely difficult. Modern methods may offer valuable inference. Thank you very much.
Thank you very much. Question?
Well, so I'm going to talk here. Nice talk. I have a question about the simultaneous time bias. Because let's say, take COVID, for example. Take a survival curve of COVID in ICU. In the first few days, nobody died. So my question is, although it's technically true to have an simultaneous time bias, how clinical relevant?
That's a great question. So the data I showed was not for COVID. That was for sepsis-related ARDS. So it's from 2017. Yeah, exactly. So it depends on the amount of immortal time, and it depends on the clinical likelihood of an event occurring before immortal time takes place. So it can be a large bugaboo. Observational studies of Paxlovid, for example, are influenced by immortal time because you have to stay out of the hospital in order to receive Paxlovid, for example. Studies of steroid therapy in the hospital are affected. And that's generally if you set a rule that you have to get 7 days or 10 days. 48 hours may or may not be enough to be clinically relevant in a very select circumstance, but it should be something that we're always considering.
Another question?
Are you asking a question? No.
No. I have a question because I'm uncomfortable with sometimes with early and late intubation because in my opinion, late intubation does not mean delayed intubation. And for example, in the article by Junduan, the HACOR score, they found that patients with early intubation had better outcomes than patients with late intubation. But patients with early intubation were more severe at admission as compared to the others. And at time of intubation, they had similar severity, meaning that patients with late intubation worsened secondarily and did not meet criteria for intubation at admission or early after admission. And therefore, maybe it's not, we cannot exclude that it's worse to worsen secondarily or despite adequate treatments. And,
when you look at those who fail late, they always do worse, even with the same disease process versus those who fail early. And some of that might be the self-inflicted lung injury that is occurring during the period of time before they are supported. Some of that might be just the fact that with non-invasive ventilation, they didn't improve. And so you're selecting for people who are likely to have a more prolonged course, so, because the patient who comes in, you intubate them at time 0, and then by time 72 hours, they have already started to have a significant improvement. However, the patients who you intubate at time 48 hours have already selected for the fact that they're not improving at that time because you thought they were good enough for non-invasive ventilation at time 0, and then they're worse. So it's a little subtlety about the direction of causality that in observational research is very difficult to really tease out. So I think, unfortunately, the only way forward is to really, I don't know how ethically or how willing intensivists would be willing to randomize different thresholds of intubation, but that's potentially the only way forward.
Another question? We move to the, yes, okay, Alexandre?
Sure.
Thank you very much, Alex Demoule from Paris, France.
Yeah.
Just, so you said like one option to answer the question would be to randomize patient and an intensivist will not be really willing to do so. Do you think that we could agree on criteria? Because before doing the randomized control trial, maybe we need criteria, intubation criteria. Do you think we could agree on some criteria, or?
Hopefully we can, but potentially the chairs probably have more experience with this than I do.
No, I don't have experience, but I'm skeptical about the fact that this is a doable randomized control trial. And that's why it's interesting what you said about alternative tools that we may have in order to answer these questions without randomized control trial. I believe would be impossible.
Nothing is impossible. Yeah.
Okay, thank you very much.
There is
a short question?
Very short.
Question and a comment, yeah, very quickly. Yeah. So, excellent presentation. I just want to say, I think this early versus late intubation and the many studies that are in the literature, I think this is a wrong question that we're asking. Because we're looking at the timing of intubation, and rather you need to look at the physiological status at the time of intubation. So what you should really be asking is at what threshold are you intubating? Not whether you're intubating early or late, because what is early for one patient, exactly what you said, may be late for another patient. So I think we shouldn't go by timing.
That's a good point.
Okay. Thank you very much. We move to the next presentation. Alexandre Demoule from France, from Paris. Maybe it's easier, ask the patient for intubate.
So, good afternoon, ladies and gentlemen, dear Chairman. Many thanks for the invitation to give this talk, which is provocative, because in the ICU we're going to talk with patients. So that's the topic of my talk, disclosures. So, when we manage a patient with acute respiratory failure and we do consider intubation, we integrate many signs. So those signs are respiratory rates, paradoxical motion of the abdomen, of course oxygenation, heart rate and blood pressure, and of course neck muscles, and the level of consciousness. So this is all we take into account to make our decision on whether or not we're going to intubate the patients. But there is one symptom, it's not a sign, a symptom, that in general we do not consider, which is dyspnea, which is the breathing discomfort of the patient. This is not the breathing discomfort you speculate. This is the breathing discomfort that the patient really feels. And in general, we don't ask the patient whether or not she or he is dyspneic, so breathing is difficult. So dyspnea is defined as the uncomfortable, abnormal awareness of breathing, but when we ask a patient, we say, is your breathing difficult? Is it difficult to breathe? So this is the way we ask the question to the patients. Do you lack air, not getting enough air? There's many ways to ask patients whether or not they are experiencing dyspnea. So dyspnea is not breathlessness. So breathlessness is what we experience when we exercise or run to catch the train. So breathlessness is something that ends when our effort ends. So it's very different. And breathlessness is not pain, because pain is not associated with the fear of dying. And as physician, as caregiver, I would say, we are familiar with pain because in this room, everyone has experienced pain at least once. But very few of us have experienced dyspnea. We have experienced breathlessness, but not dyspnea. So there's a big difference between the respiratory distress signs that we observe in the patients and dyspnea, which is a symptom, which is by definition self-reported by the patients. So this dyspnea results from in general, an increased respiratory drive. So too high respiratory loading, resistive loading like bronchoconstriction, or elastic loading like in pneumonia or atelectasis, and not enough sometimes respiratory muscles. This increases drive, which in turn generates dyspnea. There's also cortical input, such as anxiety and pain, which contributes to the genesis of dyspnea, and some metabolic stimuli. But in the case of our patients, let's say dyspnea is caused by this respiratory loading, this unbalance between respiratory loading and respiratory system capacity. So, in the ICU, can we use dyspnea sometime as a warning sign? So, for instance, there's a study from our group where we measure dyspnea on a visual analog scale from 0 to 10 during the spontaneous breathing trial. So we measure to what extent dyspnea increased between the beginning and the end of the trial. And we saw that the increase of dyspnea was much higher in patients who failed DSBT than on those who succeeded DSBT. Basically, in patients who succeed DSBT, dyspnea does not increase during the trial, while it increases a lot in patients who fail DSBT. And we also observed that dyspnea change was a quite good predictor of SBT failure, and better than for instance, better than the rapid shallow breathing index or respiratory rate change. We also using dyspnea also as a warning sign, saying that it's a good marker of increased respiratory drive and an imbalance between load and capacity of the respiratory system. We evaluate dyspnea 2 hours after extubation to see whether or not it did predict a future post-extubation respiratory failure and need for re-intubation. And we did this, it was a bicentric study between Paris and Toronto, and we did this in 122 patients, and extubation failure was 17%, and we observed that the dyspnea visual analog scale, 0 is no dyspnea, 10 is the maximal possible dyspnea for the patient, was here much higher after extubation in the patients who failed extubation and were re-intubated with a pretty reasonable receiver operating curve. So now, okay, so this is a good warning sign. Could we use dyspnea to help us to predict the need for intubation? So we use 2 cohorts, so some of them have been published. This one has been already published, whether or not dyspnea can be used to predict intubation. This one also is from the Massimo Antonelli group. And we also use the data from the Florali study. Thank you very much, Arnaud. And from the Ephraim study from the Eli Azoulay group, that I thank a lot. And then those are not published, so are quite new data that I will show you. So we measure in those cohorts the level of dyspnea and whether or not it was associated with intubation. So in this first study published, the average level of dyspnea was 40, and let's say 55% of patients, half of patients had moderate to severe dyspnea. So it's very difficult to define what is a clinically relevant dyspnea. For pain, it's easy. It's 4 on a scale of from 0 to 10, 3 or 4. And with dyspnea, people agree now that a significant dyspnea is defined by a score or 4 or more on a scale from 0 to 10, or 40 or more on a scale from 0 to 100. So in the paper from Menga from the Massimo Antonelli's group, dyspnea was 14 average, with, you see, in general, 50% of patients had significant dyspnea. In the Floral trial, it was 46, with 52 patients with moderate to severe dyspnea. And in the Ephraim cohort, 50 with 76% of patients having, here it was post-respiratory comfort, but this is pretty much the same. So let's compare the intubation rate of patients, which is the y-axis, depending on whether or not they have a moderate to severe dyspnea, which is 4 or more. And you see that in all those studies, the intubation rate was much higher in patients who reported a higher level of dyspnea. So this could be a helpful sign to help us deciding whether or not patient needs to be intubated. And in these 4 sets of data, dyspnea, a significant dyspnea, so more than 4 in a scale from 0 to 10, was significantly, independently associated with intubation in the 4 cohorts, which is quite interesting. And you can see, for instance, the survival curve, so cumulative incidence of intubation in the Floral cohort, whether patients have a light dyspnea, less than 4, or moderate to severe dyspnea. And you see in the Ephraim cohort also the relationship between the intensity of dyspnea and the intubation risk. So the next question is, okay, now we have information of dyspnea and intubation, but what about mortality? So we looked in these data sets, we looked at the relationship between dyspnea and mortality, because we could figure out that if dyspnea is high, we said respiratory drive is high and load capacity is really imbalanced. So maybe patients are more severe and maybe they are more likely to die. So, for instance, in the dangerous paper, we can see that ICU, hospital, and 90-day mortality was higher in patients who had moderate to severe dyspnea on ICU admission, and that dyspnea was independently, significantly associated with 90-day mortality. So this is really a warning sign. We have also in the Floral cohort a significant difference between the probability of survival between patients with dyspnea and those without dyspnea. And finally, in the Ephraim cohort, we have also a difference in terms of survival probability between patients with a good respiratory comfort, that was respiratory comfort, not dyspnea precisely, that was asked to patients, and poor respiratory comfort. And here again, it was the association between dyspnea and mortality was significant. And you see here a linear relation between the predicted rate of mortality and respiratory discomfort. So, in conclusion, yes, I think that it might be interesting to ask the patient whether or not she or he feel dyspneic, like breathing is discomfort. You can ask the question. There's many ways to ask the question. It's sure that if we ask, do you feel dyspneic, the answer risks to be a little bit inaccurate. But if we ask, is your breathing difficult? Is it hard to breathe? I think that it can be helpful. First, dyspnea is frequent and severe in patients with acute respiratory failure, which is another question actually, because it means that those patients are suffering from their respiration. But this is another story. It's a warning sign that we should monitor. And it's an independent predictor of intubation, at least when it's more than 4 on a scale from 0 to 10. So I think that it might be interesting to integrate this sign in our decision to intubate or not the patient. How, I don't know, but taking this information into account might be interesting. And also keep in mind that this is an independent predictor of mortality. Thank you very much for your attention.
Thank you very much. The paper is open for questions, discussions. What is the physiological relationship between tachypnea and dyspnea? And what is potentially high respiratory rate somehow replace the assessment of dyspnea?
So there's a relationship between respiratory rate and dyspnea because both are driven by the respiratory drive. But there is no linear relationship between respiratory rates and dyspnea, which means that a high respiratory rate does not predict a dyspnea in 100% of patients, and a low respiratory rate does not rule out dyspnea. So some patients may have severe dyspnea with a low respiratory rate.
The example I have is the stable COPD patients who breathe with a rapid, shallow breathing and is running a perfectly normal life, even at a very high respiratory rate and a relatively high PCO2.
Absolutely. And this is an issue, because if we could infer dyspnea based on respiratory rate, it could be very helpful. But this is not enough.
Other question?
Yes, question?
Can I ask a question? Excellent presentation, and I think this is a great concept to integrate dyspnea. And Professor just asked the question I wanted to ask, actually, what is the correlation? My question to you is, unlike respiratory rate, which we do use as a criteria for intubation when the respiratory rate exceeds a certain amount, that's very objective. But dyspnea, you're eliciting from the patient. So there is a degree of subjectivity. So how do you're talking about a scale, or how do you kind of integrate? How would you assess that a little more objectively? Because you will depend on,
Yes, but when you assess pain in a patient, do you think it's subjective? When you assess pain in a patient,
on a scale of 0 to 10.
Yes. If you use a pain scale,
something like that.
Yes, if your patient can self-report pain, you ask patients, so what is your pain between 0 and 10?
Yeah.
It's not subjective, it's objective, but it comes from the patient.
Yeah,
but from the patient side, it's objective. So we have to trust the patient. Yeah. That's the story.
But a very, very interesting concept, yeah.
Okay. Thank you very much. And we move on to the next presentation. Dr. Sheila Myatra from Mumbai, President of the Indian Society of Critical Care Medicine. Are you still President?
I just gave up, yeah.
Just past President?
Yeah.
You're always President.
So, good evening, everyone. And we're going to change gears, and now we're going to talk about videolaryngoscopy. Should it be the standard of care in critically ill patients? Before I start, I want to ask you, how many of you believe in this? How many of you would say yes? Oh, okay, that's going to make my life very easy. Okay, so this was a editorial that we wrote with some of my French colleagues, direct versus videolaryngoscopy, a game changer for tracheal intubation in critically ill patients. And I hope by the end of this, I'm going to convince you that we should be using videolaryngoscopy in all our patients today. So just some basic concepts. So what we're doing with the videolaryngoscope, essentially it's indirect laryngoscopy in which you don't directly view the larynx, but there's visualization of the larynx, which is performed by a digital laryngoscope. Now, it's very important to remember that unlike a direct laryngoscope, which is one entity, a videolaryngoscope is a very heterogeneous entity. So you're talking about different devices, and that's probably one of the reasons why most of randomized controlled trials are not, you're not comparing A with B, you're comparing it with a whole family of devices, isn't it? So just some basic concepts, because people get a little confused. So with 3 types, if you categorize them, so there is the videolaryngoscopes, which has a MAC blade, then you have the channeled blade, and then you also have, what we use is the hyperangulated blade, which is increased angularity. So this is also the 3rd type of blade. So you have to know what you're talking about when you're talking about a videolaryngoscope. Now, just to give you some differentiation, when you compare with the standard Macintosh direct laryngoscope with the videolaryngoscope MAC blade, it gives you a 60-degree indirect view, so more enhanced angle of view. Though the blades look very similar, that's what the videolaryngoscope does. On the other hand, when you use the hyperangulated blade, it gives you a more improved view, a more around the corner kind of view, and can help you even better in more difficult. So they're not exactly the same, though they may look the same. So a hyperangulated blade gives you this kind of view where you're able to see more around the corner. And definitely in an anticipated difficult intubation, you should first pick up the hyperangulated blade. So there are a lot of technical advantages with the videolaryngoscope. Of course, it gives an improved glottic view. You have a camera at the end, and it can give you a much superior view than direct visualization. And it obviates the need for the kind of alignment that we used to do between the axis and, a less force. And this is especially important when you don't want cervical manipulation. So definite advantages, technical advantages. And one of the most important ones, I think, is a shared view that your airway facilitates enhanced coordination with the team, and I'll show you that. And of course, in COVID, which was very, very useful to us, it allows further distance between the operator and the patient's upper airway, which was very, very important for us. We didn't want to go right into, look into the oral cavity. And what it really does, and where it really helps, is the teamwork. It changes the whole thing from me to we. And not only for the view, because you have a shared mental model. This is really, really important because, when you're so stressed and you can't see, have a good glottic view, there's so much cognitive overload, and you're sharing this with your colleague who's saying, okay, do this, do that, and an excellent teaching aid. So it really changes the whole thing to something that's a teamwork, me to we. And the other thing is about the use of videolaryngoscope to prevent esophageal intubation. Now, this kind of thing, this is called a glottic impersonation. When you use a lot of force, especially with direct laryngoscopy, you can see this kind of blanching, and you're not really sure, are you seeing the vocal cords, and you think you've passed it through the vocal cords. And this is where it really helps when you use a videolaryngoscope and you have a shared view with a colleague, and by enabling the other team member to view the intubation, it also provides the opportunity for them to confirm that you're actually in the right place. And of course, during airway management, like I mentioned, the videolaryngoscope was used so much, and many institutes which never used a videolaryngoscope, and many individuals which never even held an videolaryngoscope, especially in developing world, got a videolaryngoscope thanks to COVID. And there were 3 guidelines that were published for airway management in critically ill patients, and this came from the Difficult Airway Society. Then there was a guideline on tracheal intubation COVID from the Safe Airway Management Society, and we also had one from the All India Difficult Airway Society. And all the 3 guidelines that were produced during COVID said use a videolaryngoscope because there was an obvious benefit. We wanted first-pass intubation success, and we wanted to be away from the oral cavity as far as possible, and that was something that the videolaryngoscopy aided. You may have heard about the project for universal management of the airway, and this is a group of anesthesiologists, intensivists, and emergency physicians that are moving towards a universal algorithm for airway management, irrespective of geography. You don't use a DAS algorithm because you live in the UK. You don't use the American algorithm because you live there. Irrespective of geography, irrespective of context, irrespective of the type of patient, you have a universal algorithm. And one of the things that they're working towards, and were pre-published in Anesthesia, was preventing unrecognized esophageal intubations. And this came from the Puma group. And what we're aiming at, one of the things, of course, you have to use waveform capnography, but one of the key recommendations is the use of videolaryngoscope, because videolaryngoscope definitely helps you reduce your esophageal intubation rates, and this is so important to not have an unrecognized esophageal intubation. And I'm sure all of you have seen this paper that was just published day before yesterday. Big paper in JAMA, videolaryngoscopy versus direct laryngoscopy for tracheal intubation. And here they compared direct laryngoscopy with the hyperangulated blade that I talked about. And this was a cluster randomized trial, almost 8,000 surgical patients, procedures in close to 7,000 patients. And you can see a distinct difference between their primary endpoint, which was more than one intubation attempts. And clearly, this study shows that VL is a preferable method for intubating patients for surgery. And this is, of course, in the operating room. But in the ICU, we're really in a different situation. And this, we also have the Cochrane review that was published, which included both patients from the operating room as well as patients in the intensive care unit. And this was the PRISMA design and the critical outcomes. I won't go into details about that. But one good thing in this Cochrane review is they recognize the heterogeneity of the device, and they compared the failed intubation between both the MAC-VL and the direct laryngoscope, and it favored the videolaryngoscope. They also compared with the hyperangulated videolaryngoscope and the direct laryngoscope, which again favored the videolaryngoscope, and also the channels. So they looked at different types of videolaryngoscopes and compared with the direct laryngoscopes, and in all three, they found superiority of the videolaryngoscope. But of course, this was a combination of videolaryngoscope used in the operating room and used in the intensive care unit. And their conclusion, of course, that was videolaryngoscopes, produce more increased first-pass intubation success, more safer, and more prone to be compared with direct laryngoscope. But in the ICU, the situation is a little different. What we're dealing with is not just anatomical difficulty that we see in patients in the operating room. We are dealing with what we call the physiologically difficult airway. Now, what do you mean by physiologically difficult airway? Now, this is an emerging concept. We're still defining it. It's basically the critical illness itself increases the risk of complications when you're doing a tracheal intubation and transitioning into positive pressure ventilation. Now, critically ill patients often have an imbalance between oxygen delivery and consumption. And there are many factors that increase the consumption, as you know, fever, sepsis, tachypnea, while on the other side, your delivery may be compromised because of low cardiac output, anemia, your lung disease, and also the low FRC. So you're already starting with a patient with this kind of imbalance. And I'm sure you must have seen the Benioff curve before. And when you're comparing with a normal patient, when you're intubating a patient with a physiologically difficult airway or a critically ill patient, they start with a low RFRC, they may have high oxygen consumption, and if you look at the time to desaturate, which is on the x-axis, they rapidly desaturate during apnea. So this is a very high-risk group. And in addition to this, if they also have an anatomically difficult airway, that can further compound and increase the risk of complications during tracheal intubation. So it's not only the anatomical difficulty, but the physiological difficulty where you have to keep in mind when you're looking at the tracheal intubations in these patients. Now, interestingly, unlike in the operating room, and this is this randomized systematic review that's done from the Italian group from Luca Cabrini, the data in the intensive care unit for a very long time did not show any benefit with the VL or DL. And it really made me wonder, why is it that the same tool that we're using in the operating room is clearly showing a superiority over the direct laryngoscope, but in the intensive care unit, the VL and DL, no difference in first-pass intubation success. And in fact, some of the studies actually show increased complications with these devices. And one of the reasons for it, and this is very beautifully described in an editorial that was written for the Lascaruch study, which shows videolaryngoscope in the intensive care unit, seeing is believing, but that doesn't mean it's true. So videolaryngoscopy generates an excellent view of the larynx. When you have use a direct laryngoscopy and you don't get a view, you tend to give up and you just hand over to your colleague and you say, I can't see much. But when you use a videolaryngoscope, the challenge is not getting the view. The challenge is delivering the tube. So you get an excellent view and you tend not to abort because you just go on and on trying to intubate because you have a great laryngeal view in front of you. And that will be may be very well tolerated in a patient in the operating room who's very stable, has come fasted, and it would be more forgiving, but this is probably not forgiving in a patient with the physiologically difficult airway. And that may be one of the reasons why the complication rates were higher in these patients and reduced first-pass success, and not necessarily because the tool is bad. So it really means you need more experience of the operator to really show a difference, and probably why the earlier trials didn't show a difference. So just to tell you that having a great view doesn't result in a successful intubation. So getting a good view is not a challenge. You have a camera right there, right? You get a great CL1 view. The challenge is in delivering the tube, for which you need a stylet or a bougie. And this is really, really important to understand, which previous trials did not address, and probably why they didn't show a difference in the study. Now, I'm sure you must have all known about the InTube study that was published in JAMA, and I was very proud to be a member of this team, the second author on the paper. And this was the first study that looked at intubation practices globally. How are people intubating patients in the developed world, in the developing world? Until now, we had only single center studies, or we had national audits in the developed world. But this is real world practices, not only looking at the way people were intubating, but also looking at the complications related to tracheal intubation in critically ill. And it was a study that was done across 5 continents. And if you look at the primary endpoint of this study, look at the rate of complications, 45%, almost 1 in 2 patients have a complication during tracheal intubation. And unlike what we thought, it was not hypoxia, but it was hypotension. 42% patients have hypotension following tracheal intubation in ICU, and I know the next speaker is going to be talking about this. And that's a huge risk of complication, and this is because these patients have a physiologically difficult airway. And if you look at the sub-analysis group of these patients, it's really interesting to see that only 17% of the patients were intubated using a videolaryngoscope. So you know the importance of first-pass intubation success in this very vulnerable group of patients, but despite that, only 17% of people intubating in the intensive care unit actually use a videolaryngoscope. And this is not data from the developing world where you can say, okay, maybe they don't have a videolaryngoscope. This was also data from the developed world. So really, people were not using videolaryngoscopes in the intensive care unit. Perhaps maybe because it's a mixed group, they're not all from the anesthesiology background, maybe physicians, pulmonologists, etc., may not be very familiar with using it, but also not only lack of awareness, but also because the data was not very conclusive. And we did a sub-study of videolaryngoscopy, and this was published in the British Journal of Anesthesia, and we looked at these 17% patients in whom the videolaryngoscope was used. And it's really interesting because these 17% in this large cohort of almost 3,000 patients was about 500 patients, and we found that first-pass intubation success was actually higher when we used a VL, and even when we did the adjustments, it was the same, and it was not associated with any increased complications. So this was one of the first study. Of course, it wasn't a randomized controlled trial. It was just a subgroup analysis of this big study that showed increased first-pass success rates. And these findings definitely support the systematic adoption of videolaryngoscopy in the critical care unit. And we really felt that this should be further studied in a randomized trial. And that's really what we found. So in this, you see the forest plot, and you see videolaryngoscopy definitely with first-pass intubation success, cardiac arrest, and also favors less esophageal intubations. And then, of course, we have the big randomized control trial, the device trial that was published in the NEJM. And this is the first randomized control trial, large trial that showed a clear separation between the use of VL and DL in critically ill patients. And this study had to be actually, during interim analysis, had to be stopped when there were 1,400 cases. And there was a clear separation between the patients, first-pass intubation success between videolaryngoscope and direct laryngoscope, almost 85 and 70%. And the secondary endpoint was the complications, and there were no difference in the complications. Ideally, when you look at an intubation in a critically ill patient, it should be a composite endpoint of first-pass intubation success without complications, because I don't just want first-pass intubation in intubation success in a critically ill patient. I want that without complications. But unfortunately, this study didn't look at it. It was a secondary endpoint, and this study clearly showed that in the emergency department, the videolaryngoscopy resulted in higher incidence of intubation success. And this is interesting because in the subgroup analysis of this primary endpoint, and you can see all the factors that you look at favors videolaryngoscopy. However, if you look at the experience of the operator, if your operator has done more than 100 intubations, there was really no difference between using a VL or a DL. And if they had very less experience with using a videolaryngoscopy, okay, not used it much, again, there was no difference between using a VL and DL. That's something to think about. So I'll just move towards the end of my presentation. And this was an editorial that we used. Videolaryngoscopes for all intubation is direct videolaryngoscopy obsolete. So definitely videolaryngoscopy improves your first pass intubation success, has a significant role in teaching, and should be considered for all laryngoscopies. However, it's very important to remember that neither the VL nor achieving a laryngeal view generates 100% intubation success. What you really need is training and experience with videolaryngoscopy, and that is paramount to improve the intubation success, and probably why the recent randomized controlled trial showed a difference. So with that, I'll just conclude by saying videolaryngoscopes, they are a heterogeneous entity. You have to understand that different devices used for different situations, which improve glottic view and they reduce esophageal intubations. Great for teaching. You have a shared view and it supports teamwork, which is very important. Not only your, considering your, cognitive overload that is there when you can't intubate a patient, sharing the view from a me to we is really important. But most importantly, the training and experience with VL is paramount to increase the success rate with the complication. It's not the device, but the person who's operating the device and the experience and the training that's most important. And this recent randomized control has shown a clear separation and benefit with first pass success without increasing complications with the use of VL in critically ill patients. And I would say that these findings definitely justify the routine use of VL for tracheal intubation in the critically ill. And with that, I thank you very much for your attention.
Thank you very much. Question? Yes?
Yeah, Philippe Bauer, Mayo Clinic. Yeah, nice presentation. I mean, you put really the balance between the two techniques, but actually we are exploring now a third technique, which is a standard geometry.
Yeah, standard geometry blade.
So basically it's a Mac blade with a camera, because we are very concerned about the education and the teaching of our training. And
right.
You demonstrated nicely that even if you have better glottis visualization, intubation may be difficult if you are not trained. But we have less and less intubation, right? With the non-invasive intubation. So we are very concerned about the education. So do you have any personal experience about direct, straight, forgot now what I said, but I mean the...
straight blade or Mac blade? Mac blade with a
Mac blade, it's a standard geometry. There we go.
Yeah, so what you have with the standard videolaryngoscope with the Mac blade is very similar. It's just a VL with the same geometry, the standard geometry blade.
No, we are talking about DL, a Mac blade with a camera. So the operator looked like us through like a DL, but the supervisor looked like a video.
Right, yeah. So this is what we do actually, because I don't still believe that you should completely throw away all the direct laryngoscopes. What we do is we use the Mac blade VL with the screen, and the supervisor looks at the screen, whereas we blind the the operator, so he gets experience with both direct laryngoscopy, learns this, and we look at the screen, and then as you get more trained with doing direct laryngoscopy, you start looking at the screen. So it's a good way to use the same tool, the same videolaryngoscope, to train someone in DL and VL, because there are cases where a direct laryngoscope has actually rescued a failed videolaryngoscope. So we can't totally say that you have to throw out the DL and a VL is the final panacea for all intubations.
Yes, you're right. For example, before the use of video, I was in stress sometimes with a resident, because when I was on duty, always the resident tries first. And sometimes after 20 seconds, okay, Michael, are you okay? And after 40 seconds, okay, can you see the trachea? Pulse oximetry is decreasing, and with video it's very, very nice, and you are very much comfortable to maybe to intubate earlier than before.
Right, absolutely, absolutely.
And to analyze.
I think the shared view is one of the best things that videolaryngoscopy gives you. Yeah.
In line with this comment, let me be a boomers, okay? If you run out of videolaryngoscope and you have very little experience in direct laryngoscopy, I mean, you are not in trouble. You are in big trouble.
Yeah.
As an old anesthesiologist, I mean, I would first prefer to be trained with the worst case scenario and then evolve to the ideal scenario.
Right.
Because if the ideal scenario does not work, at least I have a tool.
Right, and this is the reason why from 1943 to now we are still arguing whether you should use DL or VL. Do you know anyone who'd put in a line today with an ultrasound, or a cardiologist who would diagnose without a merge by just auscultating? So unless we throw away this DL and say this is the instrument, that's never going to happen. But yes, I buy your point, Professor. But I buy your point, and that is why I showed that last slide, which was very important, because if you're experienced with both DL and VL, it really didn't make a difference. In the subgroup analysis, it showed that you're very experienced with intubations, whether you use DL or VL doesn't matter, make a difference. And that was a very important finding from that subgroup.
Very short.
Last question?
Very short, yes. Thank you for your fantastic talk. And just one question regarding the hyperangulated blade. Do you use it often in every patient, only when you do suspect very difficult intubation? How do you?
Yeah, so again, the hyperangulated is a classic thing where you get a fantastic view, excellent view, but delivering the tube is really difficult. So I would use it more when it is an anticipated difficult airway, because you do need to use a stillet or a bougie. Delivering that tube is really difficult. The view is great. So you need a lot of experience when you use a hyperangulated, and you cannot use a hyperangulated without a stallet or a bougie, because you will not succeed. You'll see the cords in front of you and the tube doesn't go in. And it used to make me wonder that videolaryngoscope, in the beginning I used to think this is a tool that makes intubation more difficult and not easy, because I couldn't pass the tube. So hyperangulated I would reserve for more difficult intubations. But this study has clearly, the study that was published in JAMA just 2 days ago, that was just released day before, has shown clearly that hyperangulated increases first pass intubation success. So definitely in experienced hands, if you're trained to do it, I think we should first move this, use a hyperangulated blade, and that would be the future.
Thank you very much.
Thank you. Thank you.
We move on to the next presentation. Sara Crager, concerning difficult intubation.
Specifically, the physiologically difficult intubation. This is something that we all need to become clinically excellent at. We can't wait until the next study tells us the best way to do it to become excellent at it either. Why? Because the physiologically difficult airway, it is a branch point moment for our ICU patients. There's a million things we do in the ICU all day, all the time. We choose pressors, we choose antibiotics. Most of those things add up. The little things add up and they matter. But there's a couple of things where what we do in moments make a huge and immediate difference, a branch point to our patient's clinical course. And the physiologically difficult airway is a huge one of those moments. Because if you get your patient through that intubation, totally fine, their blood pressure was lovely, everything was smooth, versus they code during intubation, that's a very different outcome. We need to become clinically excellent at this, especially in the ICU. Now, step 0. To begin at the beginning, step number 0 with the physiologically difficult airway is, do you actually need to be intubating the patient in the first place? And a lot of the time, the answer may actually be no. So we have this idea of safety first, right? The safe thing is just intubate the patient, conservative intubation decisions. And I actually think often safety first means waiting to intubate the patient. It's very, very rare that we have to make a decision right now, that we truly don't have time to think about this airway. Is this an emergency, or is it really an emergency? It feels like we don't have time. I mean, we've all had that feeling. You're standing there, everybody's looking at you, the patient looks like they can't breathe, the patient says they can't breathe, they're starting to desat, and you're like, I guess I gotta intubate them right now. But in reality, most of the time, you have time. It is very rare that you're truly in a situation that you can't temporize, that you genuinely have to intubate right this second, and you don't have even just 5 minutes to think. That happens sometimes. If the patient is massively vomiting and aspirating, just please intubate them right now. Most of the rest of the time, you have a minute to think, and you should use it. Thoughtfully doing nothing is something I talk about a lot in the ICU. We really want to do things. In medicine, in the ICU specifically, we love doing things. We hate not doing things, it makes us anxious. But with the airway, specifically, the physiologically difficult airway, thoughtfully doing nothing may be the most important thing you can do for this patient. Step back, look at the patient, do you actually need to intubate them? And a big part of that question is, why are they dyspneic? So I would say overall, the most important skill you need to develop is learning when to not intubate these patients. Now, I like to call this the dyspnea masquerade. The problem with dyspnea, and I'm going to build on what the earlier speakers talked about. I do think it's very important to ask your patient, are they dyspneic? But what does that mean? What are the drivers of subjective dyspnea? Some of them are lung and airway problems, right? It is absolutely the case that if your patient is status asthmaticus, yes, they are going to have the subjective sensation of dyspnea. It is the case that if they have an airway obstruction, they're going to be feeling dyspneic. It's also the case that if they have a profound metabolic acidosis, there's no lung problem. Are they feeling dyspneic? Absolutely. DKA patients come to the ED and they don't say, I have DKA. They say, I can't breathe. Shock patients. When your patient is in shock, their tissues are like, we're not getting enough oxygen, and the body's like, okay, can't breathe, get me some more oxygen. That patient, that shock patient, doesn't necessarily have a respiratory problem, but they have subjective dyspnea. And the problem with this is that if you intubate a patient who has metabolic acidosis or shock, you haven't actually fixed the problem. Now, another related issue is this whole nonsense, which proves to us that just because something rhymes doesn't mean it's true. This has been in the trauma literature. It's one of the least helpful things the trauma literature has brought us, this GCS of 8 is intubate. Now, this is a problem in the physiologically difficult airway. Why? Well, because patients who are in shock or who have a severe metabolic acidosis, are they altered? Yes, they are. They often have altered mental status. So now we're like, oh, well, okay, I have this patient. They came in saying they can't breathe. Now they're altered. Their GCS is 7.25. I guess we better intubate them. Fortunately, we now have some additional data that shows that just because it rhymes doesn't make it true. This just came out, and it was actually looking at patients with a GCS of less than 8, probably mostly had overdoses. The punchline is they randomized people to a just conservative do not intubate the patient strategy, and it seemed to work better. It confirms something we all kind of know, that just because their GCS is 7 may or may not mean that they actually need to be intubated. We need to stop conflating mental status and airway protection. They're not the same thing. One of my first jobs when I came out of residency was I was still working in the ED at that time, and I was at UCLA. And so every weekend we'd have all the frat parties, and the frat parties would happen. And so every Saturday at about 2 a.m., we'd have this sort of hallway where basically like all of the frat parties would come out, and we'd have like a huge hallway of people, lines of people with GCSs way less than 8. We didn't go around intubating all of them, by the way. Mental status and airway protection, not the same thing. I can have a patient who has a GCS of 3 because they just went to a kegger, or I can have a patient who is doing calculus, but they also have ALS. And I probably shouldn't put them on BiPAP because they're gonna aspirate, because mental status and airway protection are not the same thing, and we just really need to wrap our heads around that. All right, what happens when we do need to intubate them? How do we decide this? And as we talked about, the answer is we have no idea. This is a, if not evidence-free zone, evidence-light zone. We do not know the answer to this. There's not a magic score or test that tells you the number, and unfortunately, there's not a magic number that tells you the answer either. The SpO2 and the CO2. Everybody always wants to know at this point in the lecture, like, what O2 sat do you really need to intubate? And I'm like, well, there's no magic number. And they're like, no, but okay, sure, but like really what O2 do you intubate at? And before COVID, I would have been like, yeah, maybe in the high 80s, low 90s. And I think all of us post-COVID are like, 80s, 70, maybe. I mean, it taught us that there really is no magic number. My comfort with hypoxemia and not intubating somebody has gone way up, status post-COVID. Similarly, with the PaCO2, the other day, the resident thought I was a crazy person. There was a woman with a CO2 of 111, and I did not intubate her. And then my slides got possessed and advanced on their own. And then put her on BiPAP. Her CO2 was 98, and I still didn't intubate her. And she did fine. Why? This woman lives at a CO2 of 85. It doesn't matter what their CO2 is. It matters what their baseline CO2 is. How do I decide to pull the trigger? I mean, there's no actually good evidence on this, as we've talked about, but we kind of have to make the decision every single shift. We can't wait till that evidence comes out, so how do I do it? My organized clinical problem-solving approach to pulling the intubation trigger is as follows. I ask myself 3 questions. 1, what is their work of breathing like? 2, what is the reversibility timeline I anticipate for whatever I think is causing their increased work of breathing? And 3, what is their overall trajectory? So in terms of work of breathing, somebody brought this up earlier, and it's an excellent point. Look at this guy. I took this patient video for a reason. His respiratory rate is actually not that fast, but look at his accessory muscle use. Accessory muscle use to me, especially after COVID, has been the single most important thing that matters to me when I am looking at a patient and deciding whether I think they may need to be intubated. And just because your respiratory rate is not super high, you may still have significantly in work of breathing like this guy does. Now, accessory muscle use is a little harder to see in morbidly obese patients, but as you can see with this guy who both has accessory muscle use and a high rate, you can see it in them if you look closely. And that's the first thing I do, really. When I'm examining these patients, I look at their neck. It's the thing that's become the most salient factor to me in deciding whether I intubate them. Now, a key thing to understand here is the relationship between work of breathing and tiring out. Because my residents come to me all the time, being like, they're working really hard, I think they're gonna tire out, so we might as well just intubate them. While it is absolutely the case that work of breathing can lead to tiring out, just because their work of breathing is high doesn't mean that they're tired. These are not the same things. And another thing we learned from COVID is that people can work really hard for a long time and not get tired. Now, whether they're giving themselves self-inflicted lung injury as they're working that hard is a different question that we need to answer, but make sure to understand those are 2 different questions. So work of breathing is not the same as tiring out. It just can lead there. Trajectory. When I talk about trajectory, I both mean, right now they look terrible. They're getting a D+ on the eyeball test, but before they were getting an F on the eyeball test, so they look better than they did before. But also, what's the trajectory of improvement? Do I think this patient can't breathe because they're in heart failure and their volume overloaded, and they look really bad, but they just peed a liter, and so I expect them to start getting better? What is the trajectory of their disease course and their respiratory status? Then I ask myself, is there a real contraindication to BiPAP? Because there's contraindications and there's contraindications. And firstly, altered mental status, GCS of 8, not necessarily a contraindication to BiPAP because as we said, in fact, mental status and airway protection, not the same thing. And it's important because BiPAP is your friend. BiPAP will help you so much with these patients because it buys you time. And it buys you time to do 2 separate things. 1, it buys you time to treat the underlying problem. Because a really sick cardiogenic shock patient who's volume overloaded, wow, do I not want to intubate them? They're going to fall apart hemodynamically, and I know that. And maybe if I can optimize their hemodynamics and get volume off them, I won't have to. But I need time to do that, and BiPAP can buy me time to treat the problem. But it can also buy me time to prepare for intubation. Because what you don't want to do for the physiologically difficult intubation is just sort of off the cuff it. This is about to require some skill and preparation. I need to buy time to do that as well. So, optimal window. Start BiPAP early if you really think that they can tolerate it. Just because they're a little altered, that's okay. If they're massively vomiting, probably not. Time window of intubation, again, nobody knows the answer. But at some point, you do get forced to intubating these patients. Even patients where you believe their dyspnea is not being driven by a respiratory problem. If I have a patient with shock or a severe metabolic acidosis, it would be wrong to intubate that patient to treat the severe metabolic acidosis or shock, but sometimes you do get forced into it, and you're forced to intubate a patient with comorbid shock and metabolic acidosis. And that's okay, that happens. But if you're gonna do that, how are we gonna do that safely? Here's the thing. A well-done physiologically difficult intubation should feel highly anticlimactic. The nice thing about the anatomically difficult airway is that it's impressive. There's blood everywhere, somebody has a great story, you can be like, yeah, high five, did you see how hard that was and we got it. Physiologically difficult intubations, not so much. If it goes smoothly, it should go something like you have a very long talk with your whole team with a lot of details. You sit there sort of quietly but frantically pushing drugs, and then they get intubated and nothing happens. And everybody looks at you and is like, what was all the fuss about? And you're like, that means this went well. It's a lot of preparation, and if you do it right, nothing should happen other than the tube goes into the patient. In order to make it happen that way, you must be proactive, not reactive. Why? Because the physiologically difficult intubation, patients falling apart and hemodynamically deteriorating peri-intubation, it's a vicious cycle physiology. There's many examples of that in critical care, vicious cycle physiology, and what's common to all of them is that what you need to do is act early. So, intervene early. Now, resuscitate before intubate, it's a thing that's becoming popular in emergency medicine, and I agree, but resuscitate before intubate doesn't mean massively give your patient fluids, especially if they're in cardiogenic shock or RV failure. What this means is that you should initiate supportive treatment for whatever kind of shock they're in, if they're in shock, before you intubate them. That is what that means. And do not be fooled by the fact that they're starting with a normal blood pressure. They may still be in shock. People who can't breathe are very sympathetically activated. Fair enough, it's very stimulating if you can't breathe. So often their blood pressure looks normal, not because they're not in shock, but because they're so sympathetically stimulated because of their dyspnea. That's why I put in an arterial line. Their blood pressure often tanks immediately upon induction. I don't want to wait to know 3.5 minutes later when I recheck their cuff. Pressors. Don't have them in your pocket, have them in line and going. Even if they're not hypotensive now, give it a minute, they will be. Don't wait. I don't like to do awake intubations first line for these patients. Some people advocate that, but this is a complex patient, and I think with adequate anticipation and preparation, you simply don't need to. Induction meds. There's actually some new evidence that just came out about this in the last year. So these are 2 meta-analyses that just came out. Some guy was having a really good publication day, same first author on both of them. And basically the first one looking at etomidate as an induction agent for endotracheal intubation in critically ill patients. And unfortunately, and I was very sad to hear this, it actually seems like there is an association with mortality. For years we were like, it's theoretical, and then now we're like, maybe not so much. And the number needed to harm was not that impressive. It was like 31, it was pretty low. So that was a study that I was like, oh wow, I had no idea, I didn't see that coming. So a lot of people are starting to be like, maybe etomidate's not the answer. Propofol. This was a meta-analysis came out again same year that propofol may also have an association with mortality. Now that was a much bigger, more diverse patient population, and the effect was much smaller, but even so, these are the 2 drugs most of us have been using. Should we be using them? These 2 studies suggest maybe we need to expand our repertoire, and maybe we should be expanding it to ketamine. So this year, this study came out. This was a meta-analysis, and bottom line, moderate probability, ketamine associated with the reduced risk of mortality. Now, should we just stop using everything else and just ketamine? Not necessarily, but we should think about maybe backing off with the etomidate and the propofol and switching to more ketamine. So, we're not going to talk about bicarb because we're running out of time and it's probably not worth talking about. Instead of pushing a bunch of bicarb for no reason, we should probably just minimize the patient's apnea time. If you're worried about their pH, just bag them between attempts. Do that rather than perseverating over pushing bicarb. And lastly, patients with pulmonary hypertension. These patients are really, really scary. Take extra special care. I'll add that the thing that I'll do for those patients sometimes is I'll just add a little inhaled pulmonary vasodilator through high flow while I'm intubating them. But be aware, this is a especially high-risk patient that you need to be especially careful with. All right, so that's the physiologically difficult airway 2024. Respect its difficulty, but know that if you know how to do it right, it can be a very anticlimactic experience. But most importantly, decide when do you actually need to intubate the patient and when maybe you don't. Thank you.
Thank you very much. Unfortunately, we don't have time for a question, so we move to the next speaker, but let me congratulate for having 2 slides with data out of 15 minutes presentation. Next speaker is Dr. Alexander Vlaar. Here he is from Amsterdam. I hope you will have more data.
So thank you very much. I have almost only fresh, unpublished data, so I think it's really new. And Sara, thank you for this great introduction. Have been, I think, a better platform to start this presentation on post-induction hemodynamic instability. So who of you ever faced post-induction hemodynamic instability? Just to get awake a little bit. Yes, everybody hands up. Yeah, of course. I mean, if you did not have it, I think it would be a bit crazy. But who had unexpected hemodynamic instability? I think we should also have the same hands up. I mean, you're a very wise person if you can predict it, because then I want to have your brains. Who would like to have an alarm going off that this specific patient will become hemodynamic unstable, although the blood pressure is nice? Yes. And then would you also like to have to know what the underlying cause will be of the hemodynamic instability later on? Yes. Everybody wants it. So this is something we are working on with our group, because we think this would be helpful for us as clinicians. And I think that's what Sara was saying also. Make it very good prepared, and then have a very smooth induction and intubation. I mean, this is, I think, what we want. And this setting of a crashing intubation, I think we all know that the patient is stable, then we do the induction, and unexpected this patient crash, and then we give the phenylephrine, we give the fluid, we give everything at the same time, and actually we're just happy the patient survived the procedure. But this, I think, we could do better. These are my conflicts of interest. And I think the starting point is just hypertension. In our general setting, in the ICU, in the OR, we have more than 140 definitions of hypertension. This is a bit of an issue maybe, but I think we solved it quite well. We have a blood pressure below 65 millimeters mercury. I think we all agree now on, and also all the studies show, there is an association with increased morbidity and mortality if you go below there. Of course, there are also absolute values of systolic and mean blood pressure, but the 65 is quite defined. But you have all these kind of variations, and this makes it very difficult. The incidence, depending on which definition you use, is 5 to 99% of hypertension during your OR or ICU stay. But we are now able to predict hypertension in this setting, intraoperative, but also in the ICU. We know it's associated with increased morbidity and mortality, but with an algorithm, we can predict it and we can treat it. If we use this, we have a 73% reduction of hypertension. So I think this is something to think of also in this induction period, because the algorithm was developed in the period after induction in a stable setting. But could we also do this before induction? This is what we want to go for. So a post-induction hypertension setting, can we do the same? So we know also, next to hypertension in the OR, in the ICU, that the post-induction hypertension is also associated with increased mortality and length of stay. There are some predictive models in place to predict induction hypertension. But the problem is you have to add so many variables. So as a physician, your first working minutes to add all the variables in a system. It are time-consuming variables. So I think this is not going to work. And I think it's also not working at this moment because I don't know many people working with this kind of algorithms. Anybody in the audience is working with an algorithm entering into a computer system or anything prior induction? No, nobody, no. So it does not work at the time. If we look at post-induction hypertension, there are varying definitions. The same holds true like the normal hypertension. So a blood pressure, mean value, systolic, relative change, absolute change, combinations, and so and so. In total, this also adds up with an incidence of post-induction hypertension between 9 and 92%. So how should we work with this? What do we call post-induction hypertension? How to define it? And what is important? And I just want to test a little bit on you guys what you think is important. So is this a crasher or a drifter? This patient, on the x-axis, you see the time in minutes. On the y-axis, you see the blood pressure. You see the -5 is the patient is arriving in the operating room or in your ICU. You want to prepare for intubation. At time 0, anesthesia is given or induction, and then we have a 15-minute follow-up. It's beat-to-beat blood pressure data. So this patient, what do you think? Would you start the induction and you have 10 minutes to observe the patient to become unstable? What would you like to know? Would you like to know this patient, or you think this patient is okay? Who would like to be prepared of this hemodynamic profile of the patient? No? Maybe a few? It's good to know that by definition, the MAP is below 65. So this is defined as a post-induction hypotension. But I do not really care about this patient because I've got 10 minutes time to see what's happening and start intervening. So stable blood pressure signal, I would define him as hemodynamic stable. We coined the term as a drifter in this setting. This case, would you like to know this case? Hands up, who would like to know this case? This case goes down within a minute. So you don't have any time to intervene. Interesting thing is, by definition, it's not post-induction hypertension because the MAP is above 65. So by definition, it would rule out and would say this patient is totally fine. So here I think we need a different view on it. So what we thought, it is not only this absolute cutoff, but it's the visual picture you see here, which is a combination of many things. It is delta blood pressure, it is speed of decline, and this all we need to find to capture in one setting. So what was our aim with this study is a prediction of post-induction hemodynamic instability. In phase 1, we develop a model to classify hemodynamic instability. And phase 2, we will develop, and we're working on that now, to predict hemodynamic instability post-induction. So what did we do? We did a general elective surgery patients, data collection with non-invasive blood pressure measurements, 20 minutes around induction, like you saw in the figure. T0 is the anesthesia induction, and -5 is the period before. We have like a baseline measurement, and then we administered all the drugs during induction. We really annotated it, and this is the trace then you see of the raw blood pressure data. And what you do is, out of those raw blood data, we really have the beat-to-beat waveform. And we have this time series, again, this first period of 5 minutes, then the induction agent, then the intubation, and then the start incision, something like between 10 and 50 minutes. So what it is with developing models is garbage in, garbage out. So if you train it on bad data, you will get a model in the end, but it's not predicting what you want. So we really want to have high quality data. And then the process of featurization starts with getting out of those waveforms all the data we would like to have. And then train and test a model with several kind of machine learning models and see which model is working best in the end. So garbage in, garbage out. What we did, we used experts, 15 experts, and to label all those data in hemodynamic unstable and stable. And to get this first impression, would you like to know this patient? And do you think this is a crasher, this one you would like to know? So this is, the experts got all those displays, and with all the colored line, the procedures in the anesthesia, but also when phenylephrine was given or inotropes were given. So we could also have like a hidden crasher, like if all kind of vasopressors are given to cover up the patient is becoming unstable, we still would like to know this case. And this kind of cases where it's very stable, they were labeled also in that manner. So is the expert consistent? Yes, they are quite consistent. Are they consistent with each other? They were very consistent with each other. So I think we did quite well. It was quite time consuming because the first cases we let them rank by 15 experts, all of them. But to see whether we could speed up the process, we checked whether we can use 4 experts instead of 15 experts. And yes, it is very good possible in this setting. So we continued with 4 experts per case. If the case was labeled as unstable by 4 out of 4, it was unstable labeled. If it's 3 out of 4, it was still labeled unstable. But if it's 0, 1, or 2, it was labeled and classified as unstable. So we had a data set of 375 patients. In this, we had 78 unstable with 75% agreement and stable 279. So then we did the featurization because then we wanted to develop an algorithm that can predict those crashers and drifters in the setting. We have this data of 15 minutes beat-to-beat hemodynamic data, and we try to find out of those periods features out of the waveforms which can predict whether a patient will be a crasher or a drifter. So then you need to think about things like we look at minimum blood pressures, we look at variance blood pressures, we look at maximum blood pressures. All these kind of features are being taken out of the waveforms. We look at pulse pressure, the mean pulse pressure, and look over this whole time period to see which features can be embedded in such an algorithm. And also the decline of slope, because this is something I think which is not covered in the hemodynamic definitions currently, but this is something as physician we would like to know. Is this patient going to crash in a minute, or is it patient going to drift over 50 minutes? So it ended up with 98 features in which we used in the model to predict whether a patient will be labeled as a crasher or a drifter. We trained it with an AI model, and we had a very nice ROC curve, so we can really predict the patient being a crasher or a drifter. And what you see is only you classify a few of them, not at the proper way, but we're doing really well. So we've done now phase 1, and this is under review currently, so we are able to classify the hemodynamic instability patients. And now the next step is, of course, whether we can predict the hemodynamic instability. We will do this, so in phase A, we're going to look which features will predict the hemodynamic instability in the second phase. And of course, we will also look, can we, and we will have, we already collected the data of 1,200 patients during induction to see whether we can already provide you the information whether the patient will have a preload problem, a contractility problem, or an afterload problem, so you can already have the therapy starting during induction. So this is what we would like to do, and I think we are getting there with machine learning AI, is really predicting what's happening in the future and make life as physician, but morally, of course, for the patient, a bit more safer and better. So incidence of post-induction hypotension is high and associated with poor outcome. Current definitions are limited and focus only on one aspect, and I think it's very important to be aware of that. This post-induction hypotension is very complex setting, but actually we as clinicians all know what we mean if we talk about a crasher or a drifter. And this is a new way of looking at it. We now can classify crashers and drifters using an expert-based algorithm. Next step is building the prediction model of crashers and drifters. So I hope next year to show you that, added with the diagnostic algorithm with the prevention strategy. And the final step is, of course, work with this in clinical practice and see how it works. I would like to thank the Dynamo research group for working on this and all the other PhDs in the team. Thank you.